Boy, I don't know what this is, but I'm already excited.
It's how would I put this? It's the first time I'm doing a lecture in this format, but should be fun. I'm sorry, I wish I had a camera that was facing the right direction.
No worries. I think we're getting
Yeah,
close though, Andy. So whenever you're ready, people will probably come back in and we can get started.
yeah. Maybe a couple more minutes. Okay, we can go ahead and get started. Hello, everyone. Let's hear some hellos back or see some faces.
Hello.
Hey, everyone. My name is Andy Phan. I'm currently technically a PGY4 in the psychiatry program, but I actually finished a whole family medicine residency prior to starting the psychiatry residency. So I'm planning on being double boarded and doing increasing psychiatry education within primary care and inter other disciplinaries are is one of my goals. So hope that y'all enjoy this talk. The talk that we are having is Depression 201. And our objectives will be we're going to define major depressive disorder, distinguish it from other depressive disorders, review typical treatments for major depressive disorder, define treatment-resistant depression and its pharmacological treatments, and discuss the most evidence-based non-pharmacologic integrative methods in the treatment of depression. So either someone can shout it out or tell me in the chat who remembers the diagnostic criteria for major depressive disorder. Wait, where did the chat go?
We have Tony saying
Oh, here we go.
yeah.
Yeah, I see it.
You have it back.
Yeah. Okay, Siggy caps. Okay, what about Siggy caps? Okay, yeah. So sleep, insomnia, guilt. Okay. Okay, so I'm seeing duration greater than 2 weeks, and it has to have impact on function. Yeah. Anhedonia. Oh, sorry. Interest. Ooh, there we go. Okay. Luke is currently the closest one, but still there's one little detail missing. Which one of the SIGI caps is required? Yeah, there you go. Okay, so the diagnosis is, here we go. SIGI caps for 5 out of the 9 for at least 2 weeks. At least one of the depression symptoms has to be dysphoria, depression, or anhedonia, and it has to have psychosocial impairment. And why does this matter? Well, there are a lot of different mimics and subtypes of depression that basically, if they don't meet all the diagnostic criteria for major depressive disorder, then the treatment path is totally different. There are studies showing that basically if the PHQ-9 is like from 5 to 15 and they're meeting all that criteria, then you can do therapy, you can do SSRIs and such. But if it's anything outside of that realm, say that they are meeting 5 of the 9 criteria, but they're actually functioning just fine, which is that that last question of the PHQ-9 that talks about how impactful is this in like your daily life? Is it not at all? Some days, every day, etc. If it's not impactful at all, then maybe they're just sad. That's it. They're just sad. So cool. And let's see. Good. Any questions about that? Quick diagnostic tidbit.
Andy, there was a comment in the chat just that flew by. What about using the PHQ-9 itself as a tool for making this diagnosis?
Yeah, so that's a very good question. So I think that the PHQ-9 is obviously a screening tool and should be used as such. And it can be very easy to slap on a diagnosis of MDD or even some kind of depressive disorder with just the PHQ-9 alone. But in the end, you do have to talk with the patient and kind of tease out exactly what those symptoms are like. And also in conjunction with the patient's like medical history and comorbidities, like is this a depression that is related to their medical condition, and that really if you just treated the underlying medical condition, then their depression would get better, or as such, that's not something that would be beneficial to go like the antidepressant route, or is it something like they have an eating disorder that's leading to the depression, um, or they have some kind of personality disorder, etc. So even when I get a PHQ-9 result, I definitely look at all the symptoms that they marked very highly on, like they marked a 3 on, and then I kind of ask more about those and explore a little bit more about how it's really impacting their life and such. So yeah, hope that answers the question. So, and let's see. So major depressive disorder, reviewing the diagnosis here. And why does this matter? There's a lot of good epidemiological data out there. Like the lifetime prevalence of a major depressive disorder ranges from 10 to 20%, with women being more affected than men. That's a lot of people, y'all. That's like 1 out of every 5, 1 out of every 6 people that y'all see will have at least one major depressive episode in their life. So older individuals are 13% of the population, but are actually 20% of completed suicides. MDD is a common, often comorbid with poor socioeconomic conditions, medical conditions, anxiety disorders, substance use disorders. So like half the patients at Harborview, 30 to 40% of individuals with MDD also do not respond adequately to first-line antidepressants for treatment. and the risk of recurrence for after one depressive episode is actually 50%. And after two depressive episodes, it's maybe about 80% based off of some landmark studies that we have. So depression is a huge global burden, and I would say that with our generation, it's especially becoming more, I would say, prevalent as we're becoming more aware, and it's something to really focus on. So the first thing I want to talk about and that I've mentioned is that we have depressive disorders here. And the way I like to think about it is that I break it up into two categories here, that there's subtypes of MDD and that there's also mimickers of MDD. So subtypes, and this is kind of more of the nitty gritty, but subtypes would be, for example, like if someone has what you call atypical depression or melancholic depression, which is the typical depression, and peripartum depression. Here we go. The peripartum depression, psychotic features, seasonal pattern. And this is important because with some antidepressants, in practice, you may prefer to have other first-line agents for these types of depression. So for example, bupropion is actually an okay, it has an okay indication for first-line treatment of major depressive disorder, but not for comorbid anxiety disorder. Let's see, oops. Sorry, is this big enough, by the way? The font on here? Or should it be bigger? I can zoom in. Is that better?
I think it's all good. I just have old eyes.
Okay, just wanted to make sure. Let's see. So, you know, there's some nitty gritty about like which antidepressants are quote unquote like activating versus like more sedating. In general, they're typically all the same, except bupropion it does tend to be a little bit more anxiety provoking. But otherwise, the only interesting things about identifying these subtypes of depression are that if you have, say, atypical depression, so you're more like having more lead and paralysis, you're having like overeating issues, more like psychomotor retardation issues, then some people like to pick like bupropion, for example, because it's more like activating, energizing. It has more of that norepinephrine adrenergic effect, so it can have a more energizing effect with people. Whereas opposed to some people will say like with the more typical depression, they're having some insomnia, they can't go to sleep very well, they're having a lot of racing thoughts, a lot of rumination, a lot of guilt, then people will sometimes just trend towards a sertraline, which is supposedly more sedating, but in all actuality, your mileage may vary. Let's see, and yeah, and then identifying catatonic, psychotic, peripartum depression may require some more rapid treatment. Catatonic being more of like the psychomotor agitation, especially getting like really difficult having thoughts come out, and that you would see this, I guess, more in the hospital. Obviously, psychotic features, you would want to trend towards either starting like an antipsychotic or referring to a psychiatrist, and then peripartum depression. Well, we can talk about that a little bit later too. So the next thing I want to talk about are the mimics. What are some other either psychological, psychiatrical conditions that are very similar or close to major depressive disorder? What do y'all think? So one example could be like adjustment disorder with depressed mood. Good, bipolar disorder. Good. Hypothyroidism. Okay. What else? I have about 11 here. Substance use disorder. Good. Grief. Yeah. So I'm going to rename that to bereavement / prolonged grief disorder. Um, and this one will be substance medication induced. Yep, dementia. So I have that under neurocognitive impairments. Yep, medication side effects. Good. That goes under medication induced here. What else? Yeah, Parkinson's. I'm labeling that under neurocognitive, but that's good too. Anything else y'all can think of? Anemia. Yeah, good. So that goes under a bigger bucket. Depressive disorder due to medical condition. Thyroidism, hypogonadism, anemia. Yeah, good. Anything else y'all can think of? Dysthymia, good. So I don't know when along the medical school education route that it changed, but it's now called persistent depressive disorder. But I think people learned it as dysthymia. ADHD, awesome. Yeah, good. Okay, y'all got a good amount. So some other more niche ones. Prevalent um, in the residents, burnout. It's not an official DSM-5 diagnosis, but I think it's very important to recognize. Let's see, especially those who will be taking care of more like younger folks too. Let's see. So 6, 7, 8. Yeah, hypoactive delirium. Awesome. Delirium. Dysthymia. Let's see.
You have 2 number 2s if your count
Uh,
matters.
it does. Thank you. 9, 10. So premenstrual dysphoric disorder. And then here we go. 11 is borderline personality disorder. Can't forget that one. Any questions about any of these guys? Or like typically like what's the difference between some of them, or you'll have questions about like how some of these will present differently from major depressive disorder. Okay. Um, so just a reminder to persistent depressive disorder. It's basically that you're spending a lot of your time in the 1 to 4, 1 to 4 SIGI CAPS criteria, but it's like for 2 years. And you never really quite fully meet criteria for full major depressive disorder. Also, I didn't put on here, I forgot to put on here too, just like sadness in general. Like I had mentioned earlier that, people like sadness is a normal human reaction. Like if your dog died or like if you failed a huge exam or like you got some bad medical news, even though like you're typically okay, like it's normal for all of us to feel sad every now and then. It really like like I said, goes back to whether or not it's impacting your daily functioning life or not. Yeah. Okay. Cool. So, any questions about the depressive disorders, subtypes, and such?
I think that adjustment disorder sometimes trips me up. Like, if you could explain that one too.
Yeah. So that's a good question. Adjustment disorder will always have some kind of defining event. Where so with MDD, like it doesn't necessarily have to have an event. You can just kind of feel sad or depressed overall from your overall condition of and quality of life. Whereas adjustment disorder will always have some kind of specific life event that happens, and it doesn't meet full criteria of a major depressive disorder. So it can kind of like have the 4 SIGI CAPS criteria. It can even have like 5 out of the 9 SIGI CAPS criteria, but there's no anhedonia and there's no like suicidality or dysphoria, and it will still count. That's where it gets like very nuanced. But at the end of the day, like when it's diagnostically unclear, um, and obviously like you might not have as much time to like spend with the patient to really tease out that specific diagnosis as well. You can still venture into like, hey, seems like it's a very traumatic event for you, or seems like you're going through a difficult time in your life. Like, would you want to do some therapy? Or like, would you be interested in that? Because I think that therapy is always a good first line option. I think we could all benefit from some therapy, whether or not we're depressed. And so it's always a good recommendation, CBT, or even just like some brief supportive psychotherapy. Whereas opposed to if it is just like adjustment disorder with depressed features, then the antidepressant by itself might not be that helpful. Whereas therapy recommendation, I feel like can always be like universal. So let's see. Depressive symptoms in the setting of cancer. When may it be considered MDD, or does it fall outside of the normal reaction or consider treatment? Yeah, so that's a tough question. It it would sometimes it can be, I would say you can have both, like a depressive disorder like due to cancer, but then it also leads to a general like getting the other conditions of SIGI CAPS criteria. So for example, like maybe your cancer and like chemotherapy, you're getting some difficulty with appetite, you're getting some insomnia, you're in general getting like dysphoric, but maybe you're not meeting all the full SIGI CAPS criteria there. So then you're just depressed due to your medical condition. But I would say like once it reaches into the other domains and you're not really be able to function in life clearly, there's the difference between the patient that has cancer that is losing all their hair, but they're still very happy and they're just like tired and going about their day, versus the one that now they're bedridden and having thoughts of giving up and thoughts of just ending their life too. So yeah. The difference between adjustment disorder with depressed mood and burnout. Yeah, that's a good question too. And I don't have the perfect answer to that. I would say mainly because with burnout, like it's more of a recent buzz, I would say, that's happening, and there's actually not any official like standard DSM criteria, or for that matter, like a standard definition or agreed upon like in the literature diagnostic criteria. And so I would say that burnout has to specifically deal with more demoralization, depersonalization, um, and also has an element surrounding more of value in what you're um, what you're doing in your life at that moment. And so whether it be like demoralized in maybe like a prominent hobby that you used to partake in, and then now you're not as interested in it, or particularly at work where now you're just more disinterested, apathetic, or even like I would say apathetic, but not necessarily disinterested. And you just don't have the energy to be able to function within work as well. But yeah, good. Thanks. And there's a lot of upcoming literature about that. So, okay, good questions, y'all. So the next part I want to go into is typical treatments. So how I want to split that up is medications, therapy, and response. So let's see. How do I do this without giving it away? Oops. Okay. So this might be painful, but can y'all list off the medication classes that y'all can think of when you're diagnosing someone with MDD and you're like, okay, I want to start this medication right here, right now. Here's the risk benefits alternatives. Okay, cool. SSRIs, SNRIs, and I will label TCAs under atypical antidepressants. Cool. What are some SSRIs that y'all know? Cool. Yep. Let's see. Yep. Those are basically the standard three that I would use. Good. So escitalopram, sertraline, and fluoxetine. Some people might have heard of also fluvoxamine. I'm not sure if that's like a regional dependence as well. There were some like COVID studies with fluvoxamine showing that with people who were initiated on fluvoxamine had like it was used in like prevention of like progression from mild to moderate COVID and faster recovery and symptoms, et cetera. So, but I think it might be more of like either a European or even like an East Coast thing. So good. Okay. And then there's also citalopram and paroxetine. Now, obviously I list them separately. What's the issues with these guys? I basically never want to use these guys. GI upset, sexual dysfunction. Okay, yeah. So paroxetine, it has the shortest half-life. So therefore, most side effects. It has like a fast on, hard hitting kind of effect. So it most weight gain, most sexual dysfunction. And honestly, there's not really much benefits to paroxetine or at all, in my opinion. Citalopram, yeah, good. So QTC prolongation. Basically, you can't really use it if it's greater than 40 milligrams. And basically, the minimum like therapeutic dose in the studies is 40 milligrams. There have been some like follow-up studies that kind of showed that it's like not that big of a risk. But sometimes it's like, obviously, if you get caught up in a lawsuit or like if the patient starts to have like an arrhythmia, you're gonna like think about like, oh, was it the paroxetine or was it the citalopram that I started? Like, even if they're only 20 milligrams, like you don't want to take that risk. And then you have to think about, oh yeah, good. black box warning for pediatric population, short-term increased suicidality. So that's actually all the way up until like I think age 25. And that includes all of the SSRIs, SNRIs, as well as some bupropion too. So that's a good point to look out for. Good. Okay. And what are the 2 SNRIs that y'all can think of? Yeah. Venlafaxine. Good. Yeah, if y'all think back to sketchy. Okay. So duloxetine, sorry, venlafaxine. These are useful to think about because they have some other reasons that you could use. So what's a common reason why you would want to reach for an SNRI if someone has major depressive disorder and a comorbid, like questionable condition? Yeah, good. So it's technically specifically chronic MSK pain and neuropathic pain. But some people will also try to use it in other chronic pain issues too, as well as like fibromyalgia, etc. too. So good. And there's one thing as well, is that it can be mildly helpful as well for hot flashes in menopause. Good. And what are some specific risks that you are taking into account whenever you're trying to counsel a patient with about the negative side effects of? Oh yeah, good. Endometriosis pain. Cool. Okay. You're like, oh, this patient has this very common chronic comorbid condition, so we should probably not start with an SRI. Hypertension. Yeah. Acute discontinuation syndrome is also something you want to talk to them about. Yeah, good. And venlafaxine. Yeah. So acute discontinuation syndrome is mostly with SNRIs, but it's this feeling of like headaches, dizziness, instability, kind of like brain fog if you like miss even like 1 or 2 doses. So it is something that they have to take pretty regularly. Fluoxetine actually has the longest half-life. And so if you have questions about like someone having questionable compliance, fluoxetine might be one that you would reach for, since if it might be okay if they like miss a dose or 2, since it'll still linger around in their system. So, and yeah, cool. Okay, atypical antidepressants. So that's where we're talking about bupropion. I can't spell. And this is technically considered a norepinephrine, nephrine, and dopamine take inhibitor. So when would you want to reach for bupropion? Yeah, good. Mirtazapine too. Cool. Noradrenergic, serotonergic, specific. Comorbid ADHD. Yeah, good. Yeah, sexual side effects. Awesome. So, ADHD, it has, 26. It has less sexual dysfunction and also helpful in tobacco use disorder. some good tidbits there. And I think you all will know some of the one relative contraindication for bupropion is. Yeah, good. Cool. Some also good things for bupropion. It can be like weight neutral or even like less appetite as well. Yeah, you definitely, for that reason, you definitely should not use it in bulimia as well. Good. Okay, cool. Mirtazapine, I think y'all can talk about like when you would reach for mirtazapine. When do y'all see mirtazapine most common? No, y'all are right. Yeah. So it's good that it is it's for insomnia and appetite stimulant. And obviously that's a negative side effect too, drowsiness, weight gain. Um, there's also this interesting interaction of like risk of serotonin syndrome with linezolid. So but yeah, it's definitely something that you can use as like a primary antidepressant for your elderly patients. I've had it particularly be successful for a few my geriatric patients. It can also be helpful for those who may also have like a comorbid medical condition as well. That's leading them to have like some insomnia. They're having some appetite issues as well, like for example, in patients with cancer. And so, yeah, the only thing you have to worry about too, obviously, is just making sure they're not getting like too unsteady or like too drowsy with the medication. So typically you just dose it at nighttime. So, yeah. So these are actually all of like your first line medications and all of the ones that you should feel comfortable reaching for whenever you have any patients that come in with MDD. The other medications such as like TCAs, even like trazodone and such, those would be more considered second line, and I wouldn't reach for those immediately out of my toolbox. So just kind of going over the response and monitoring component of this too. I found this nice graphic. Let me see here. Found this nice graphic here. It's from like an Oregon medical school kind of like algorithm or whatever. So you, like I mentioned, you can discuss psychotherapy literally any time that you want during the treatment modality. Everyone could benefit from some therapy. So you want to reach for the SSRI, SNRI, bupropion, mirtazapine, and then you kind of go into this bucket of, is there no response, partial response, or remission or response, with the response being defined as greater than 50% in depressive symptoms, and that's usually dictated by your PHQ-9. Or if you want to get really fancy, you can use like the Hamilton depressive scale too. But typically, I think it's easier for the MAs and such to just give them the PHQ-9, and you can kind of track it along with each visit as well. And that's when we go into talking about where after usually 8 to 12 weeks, or even like just 4 to 8 weeks, if they have that response, then you usually consider continuing up until like 4 to 9 months. And then after the 6-month mark is actually when you can think about doing like a taper if the patient's interested. I wouldn't necessarily bring up a medication taper unless the patient is like willing and motivated to do it themselves. kind of like when you do like motivational interviewing for substance use. And then partial response, maximize the dose if tolerated. And otherwise, you can go into switching to first line agent and such. So we talk about either switching or augmenting as some options. So we can talk about that. So treatment resistant depression. Any questions, by the way, about this algorithm? Okay, so the outline for this section, I'm going to talk about the diagnosis of treatment-resistant depression, the evidence for it, and then your switching and augmenting strategies. So in general, there's actually no unified diagnostic criteria for treatment-resistant depression. It's kind of like this term that just like pops up in the literature, but it's not like a DSM-5 official like diagnosis or anything. But people try to define it as like a major depressive episode that doesn't respond to two adequate trials, I should say, of antidepressant monotherapy. And again, like we mentioned above, like an adequate trial of antidepressant monotherapy would mean at least 6 weeks, 6 to 8 weeks at a minimum therapeutic dose. And you can see like what the minimum therapeutic dose is on Up to Date. Usually it's kind of in that middle range. So like if you start someone on Lexapro 5, the minimum therapeutic dose is usually around 10. Same thing with like sertraline. It's like you can start them off on like 50 with the main goal of like getting them up to like 100. And fluoxetine is like 20, I believe, and then it goes up to like 40. So, and then from the STAR-D trial, we actually have some robust evidence saying that only about 40% of people will achieve remission after just one medication trial, and another 30%, 31% will be able to achieve remission after they either switch to another antidepressant or augment their initial antidepressive treatment. So these are pretty abysmal numbers. Like the treatment effect size for antidepressants are actually pretty abysmal. And if you're thinking about it, like this is at least like thinking about like 3 months or so until you at least get some kind of like remission status for depression. So it's a pretty grueling process, but and you should expect that when you have your initial visit with the patient, that you want to follow them up. I say usually around like 6 weeks or so. Sometimes the schedule permitting, I like to see them around like 4 weeks, or sometimes as long as 8 weeks. But they should have some kind of like intermittent, at least like either phone call, or if there's like some collaborative care that's happening within the clinic, like either a social worker or like a nurse can reach out to them and just ask them like how are they tolerating a medication at 4 weeks in. They're not having like increased suicidality, or like if they are, they're not having any kind of plan and such. But either way, I think that the typical follow-up timeline would be like you see them and then you see them 6 to 8 weeks later, and then you assess on whether or not you need to augment or switch or just continue. And then if you see them for follow-up, I would still say, or if you just continue it, I would still say that you see them in like another month or two. And then same thing applies for the switch or augment. It's like give the new agent or switching agent like another 6 to 8 weeks of trial as well. Okay, and so we talked about some augmentation as like a strategy, and some of the evidence behind this too. That so when you're cautioning before augmentation, like I mentioned, you want to make sure that your antidepressant is at least a minimum therapeutic dose. So I see like some people will start like sertraline 25 and then kind of keep it at 25 until the 8-week mark. And then they're like, okay, let's bump it up to 50. And then they're like, the patient's still not seeing any effect. And then you kind of just switch off of sertraline a little bit prematurely, when the minimum therapeutic dose should actually be more like around like 75, even like 100, 125 mark. And this trial actually showed that the more like low to mid range of SSRIs, SNRIs were more optimal in terms of antidepressant effect and minimizing side effects. So one common strategy that I have is like, say, for example, I'm doing sertraline, and maybe they might be a little bit more like historically sensitive to side effects of medications. So what I'll do is I'll say, okay, start at 25 for 6 days, 25 daily for 6 days, and then increase to 50 milligrams daily after that. And then we'll see you after a month. And then if they're tolerating that well, not having any side effects, then I can go up to 100. And then I won't technically determine if they've had like a full or partial response until I see them at that 100. Or some people can also reach like the therapeutic response at, say, like the at the 50 milligram mark. So it kind of just depends. Some people will respond more on that lower end. But when you're starting to push doses like 150, 200 milligrams, you are starting to get into that like risk outweigh the benefit area. So that could be like an area where you could think of either just like switching outright after that, or you can just push the dose if that's something that the patient wants. So, and Cheng et al. Helped also reaffirm that although antidepressants can start working early on, peak efficacy could also sometimes be reached as late as 12 weeks. And that's kind of confusing, but basically one strategy is that if you do have the if you're at the 8-week mark and they have like maybe like their PHQ-9 went from like a 19 to like an 11, you're like, okay, that's basically like a pretty good response. Like, might as well just like continue it at the current dose, or if they're already at like the max dose that they can tolerate, let's try for another month and see how you do. And then at that point, you can kind of gauge whether or not like adding another medication or would be helpful or not. Any questions on kind of this more like evidence stuff before I move on to the actual like augmentation strategies? And
Hey, this is Olivia. I just have a quick question.
yeah.
I think I'm not super familiar with the, because you mentioned kind of making sure you trial them on a therapeutic dose.
Mhm.
Would you briefly, just for the most common SSRIs, letting us know about the kind of minimum therapeutic dose for those?
Yeah, that's a good question. So let me just make sure I have it correct before I say it wrong. But typically, I'll go over them real quick. So for example, with Lexapro, usually the minimum therapeutic dose that patients get to is about 10 milligrams daily. So you can start people off on like, usually what I do so that they're not like stuck in this weird window is that I prescribe an initially like if 1 to 2 month supply of medications, where the first 6 days is actually like a 5 milligram dose daily. And then I give them the instructions that if they're tolerating it well, then they can go ahead and switch up to the 10 milligram daily tablet. And then that way, when I see them, that they've already had like the adequate like bump up to the minimum daily dose. And then I don't have to like waste time of like having them be at like this sub-therapeutic dose and then like increasing. So Lexapro or escitalopram is 10 milligrams daily. Sertraline, I want to say is, I would actually say it's more like 100 milligrams daily. And then what was the other one? Escitalopram, Lexapro, fluoxetine. And then fluoxetine are, let's see, fluoxetine is 40 milligrams or so. So let's see. Actually, 20 and 40 is good too. Yeah, 20 and 40. So some of these are just like really random, but basically either the initial dose daily that it says on up to date is good, and it's also like the minimum, like a medium range after that. I hope that answers your question.
Yeah, that's perfect. Thanks so much.
Yeah, yeah. Okay. So augmentation strategies. I think it can sound all very daunting, but it can all be summed up here. So augmentation strategies, you either have your SSRI or SNRI, and then you add your atypical antidepressants. So that actually includes like your bupropion, your mirtazapine, also includes tricyclics, MAOI, which, tricyclics a patient might be taking for some other reason as well, such as for chronic migraine prevention or like fibromyalgia too. So you're kind of hitting two birds with one stone. The SSRI, SNRI, atypical antidepressant plus an atypical antipsychotic. So the ones that have been studied most are actually aripiprazole, quetiapine, risperidone. And those seem to work more than like cariprazine or olanzapine. Olanzapine has some decent evidence when combined with fluoxetine, but there's just like so many negative side effects with the olanzapine that I would tend to stay away from it, mainly like the metabolic side effects, and it's like extremely sedating too. And then the aripiprazole, that one I would say is like the one that I would reach for immediately off the bat. So with aripiprazole being a little bit more quote unquote like energizing, activating as well, and quetiapine being more of like on the sedating side if you need that side effect profile. And then once you're reaching like this lower number, then that's when I would think about referring to a psychiatrist. So that's when you're like augmenting with lithium, augmenting with thyroid hormone, even in the setting of like them being euthymic, or euthyroid, I should say, and then also ketamine as well, either like intranasal ketamine or there are some like newer studies about like intravenous ketamine as well. So questions about this? Yeah, so the question of adding atypical antipsychotics before TCAs, MAOIs. Yeah, I think that with TCAs, MAOIs, their side effect profile is actually just like are objectively worse than atypical antipsychotics. Like atypical antipsychotics, like we give out quetiapine all the time for like some delirium, risperidone for like if someone's like really needing like some agitation, etc. too. So with lower doses of the quetiapine, like either even like 100, 200, can sometimes be enough too. I think that the side effect profile for that, and I think that the QT prolongation is theoretically less so than like your TCAs. And then with the MAOIs, I think that just so many people have hypertension that it's just annoying to have to deal with MAOIs and as well as like the either like hypertensive crisis or like even a potential like serotonin syndrome with the MAOIs as well. So atypical antipsychotics tend to be more ironically safer. Yeah. Okay. Any other questions? Okay, cool. So, and lastly, let's move on to some procedural, non-pharmacologic, and integrative treatments for depression. So what do I mean by that? I mean ECT, TMS, non-pharmacological measures, and also supplements and the future. Okay, so TMS, ECT, I personally didn't really know much about TMS whenever I was going through medical school, so that might be like a new thing that y'all hear about. TMS is very similar to ECT. You basically just get a bunch of magnets put to your head, and then you go in like either similarly to ECT. There's like a brief initiation period where you can start off getting treatments like 3 times a week for like a month, and then it kind of tapers off to eventually like once a week or even like once every few weeks. But it's the side effect profile is a lot a lot more forgiving than ECT. You do still have like some issues with headaches and brain fog, but it is something that insurance can cover more easily than ECT, and you can always just like add it on to your strategies as well. Especially like when patients don't want to take more medications, but they're willing to try other modalities too. Electroconvulsive therapy, it's still extremely effective, even though it has a very poorly viewed negative side effect profile. But especially like for patients with life-threatening SI behavior, someone like you're basically needing to have it go into the hospital, or if they're having more like catatonic features of your depression too, and maybe you're seeing that they're having even like a little bit of rhabdo on the inpatient setting because of it. So and also side effects of headache and anterograde amnesia as well. Some integrative approaches. What are some of the integrative approaches or like non-medical, non like supplement based things that y'all have heard about that could be used for depression? Oh no, gave the answer away. Anything y'all can think of? Yeah, good. Acupuncture. Acupuncture, massage therapy. There's a lot of data with exercise therapy. And that doesn't even mean like that they have to get into like a specific like exercise regimen. They could literally just be walking every day, and then that starts to really increase their amount of like dopamine and serotonin that's flushing through their system. Within that also like specifically is yoga and Tai Chi. That can be very particularly helpful when counseling some of our Asian populations here in Washington as well. There's other therapy modalities. So that's like mindfulness based therapy, interpersonal, family couple therapy, supportive therapy, and music therapy. And then there's also some new and upcoming research about kind of digital therapeutics versus like, so basically like a game-based way of treating your depression, especially if like you're more tech savvy folks. You can go into like more app-based ways to tackle depression. So there's stuff like Habitify, I think it's called, and other ways, also Forest. These are like some apps that you can use to kind of like gamify like positive habits. There's like journaling there's journaling apps that can be involved as well. And then there's also like within this category, like AI-based therapy. So literally having like therapy with ChatGPT and somehow it's like helpful. But yeah, those are some interesting new things that are gaining some ground. So cool. Okay. And then some other things that we can talk about as well. So supplements, these are the more like commonly used / also like studied supplements, with I think ashwagandha having some of the more robust evidence. Um, the dreaded like St. John's wort. It's somehow everywhere, and we still like I don't like. I think it's this weird thing that we don't really know what it does, but it's like anticholinergic, kind of antihistaminergic as well. Um, I had never heard of this one, but SAMe and then omega-3 fatty acids. So you can tell your patients to be more like Mediterranean diet, more like nuts, fruits, legumes, stuff like that. Some future directions that, or still things that need some more, I would say, investigation. So y'all might have heard of something called like vortioxetine or Trintellix. It's like touted as this like serotonin modulator. Basically, there's no head-to-head trials of vortioxetine comparing like it to SSRI. They only compare it against placebo. And so there's not really any proof that it works better than any of the other treatments. So I wouldn't reach for this unless you want to just like make your patients poor. And then nifazodone, vilazodone, trazodone, they're all similar class, but they just don't have much like evidence supporting their treatment um, in depression. But you can use trazodone as like an adjuncting agent as well. Psychedelic research, it's up and coming. Psilocybin, definitely one that's gaining some traction, has some promising research, and then also some ecstasy as well, MDMA-based therapy. This is also particularly effective in PTSD and trauma-based therapy as well, as in like they use MDMA or even like LSD as well in combination with talking like exposure-based therapy as well. Gut microbiota, modulation, it's exactly what it sounds like. And then glutamate GABA neurotransmission modulators. Y'all might have heard of the new FDA approved medication for postpartum depression, which is zuranolone. And that's something that is new on the market, got approval like I think a couple of months ago, and is specifically involved with postpartum depression. So yeah. Any questions about any of this? Cool. And so without further ado, just to help sink in um, some of the knowledge, let's go through some questions. Okay, imagine this person's like 19 or 20.
We're scared of the youth, Sandy.
I know. Even 18 is like, ooh. Give y'all like a minute for it, and then we can shout out an answer, or you can just put it in the chat. Yeah, good. Why do y'all say B? I think it's literally just like there's only arguably 3 out of the SIGI CAPS criteria. And yeah, good that there's also an event too. Good. Cool. Okay. Let's see here. Let me see where that come go. 6. I might not have touched upon this one, but what's y'all's best guess? Yeah, good. B. Literally, exercise is like one of the best non-pharmacological things you can prescribe a patient. So by making them walk, you can keep them from being depressed too. And also like gives them some bright light therapy. Okay, good. 27. What do y'all think on this one? I hear a B. What else? A. Why A or why B? Yeah, it's a tricky question. It definitely showed up on my boards. But yeah, y'all make a good point that it's basically like, is she wanting help? And like, does she think that it's a problem? Like, is there actually any kind of like impairment at all, or is she literally just sad? And that's it. So, the answer is actually A. The official answer is A, but I think in reality too, I would offer B if I sense that she's having like some kind of functional impairment, or if she's like maybe having some kind of like bereavement or grief, and that she wants some therapy to go on to help with this. So pregnancy test. That's a good thought. Okay, 30, 45. So 30. This can be our last question. Oh, no, too easy. Y'all know it's citalopram. 45. 45. Okay. I know this one's like so the answer here is actually A. And there's a lot of like there's a lot of discussion on the ABFM forums about this answer. Like I don't low dose lithium is not my first choice here. But basically, I think the point that they're getting at is that 20 milligrams is actually a pretty low dose for citalopram, and that they would actually want you to at least try um, for a higher dose of like 40 milligrams prior to saying like she failed it versus versus like trying to augment. Because technically she did have a partial response here. So you could try like low dose lithium, like it's technically not wrong. But it's just also like kind of a terrible option. So okay, that's all I have. So I will send y'all the more completed mind map, kind of like what I went off of. And do y'all have any questions for me?
Andy, this was awesome. I would love if you'd be willing to share this. I would love to have it and distribute it to the residency because I think this stuff comes up a lot, and sometimes it's just like, well, what does a psychiatrist think?
Yeah.
And I love this method of sharing information. Really cool.
Yeah, awesome. Thank you. Yeah. Cool. I'll just respond in that one group email with this.
Yeah, that'd be great.
Yeah. Okay. Sounds good. All right. If there's no other questions, thanks for having me, y'all.
Thank you, everyone, for coming to Academic Half Day. See you next week.